Welcome to Diagnosing Health Care, a podcast featuring thought-provoking conversations about the latest legal, policy, and regulatory issues in healthcare. While these issues may seem like hurdles, we'll also look at the business opportunities and solutions that exist. Diagnosing Healthcare is brought to you by the healthcare lawyers at Epstein Becker Green, a leading law firm that has more than 40 years' experience serving clients in the healthcare industry nationwide.
Today on Diagnosing Healthcare, we dive into what healthcare providers can expect from OSHA's permanent COVID-19 standard and the agency's ongoing enforcement blitz. Hello and welcome. I'm your host, Tim Murphy. I'm an attorney at Epstein Becker Green's Healthcare and Life Sciences practice based out of our Boston and Washington, D.C. offices. The Occupational Safety and Health Administration, or OSHA for short, reopened the comment period for its permanent standards to protect healthcare and healthcare support workers from COVID-19 in the workplace and held a virtual hearing on the standards last month. Meanwhile, OSHA has been engaged in an enforcement initiative conducting inspections at provider facilities previously cited for COVID-19 safety violations. On today's show, we're going to talk about the provisions of the OSHA standards that may be kept in place and what's expected to change. We'll also discuss how the standards and the agency's enforcement push are impacting healthcare providers. If you like what you hear today, please subscribe to the show, Diagnosing Healthcare, and it's available from wherever you get your podcasts. Joining our discussion today is Denise Dadika, a member of the firm in our Newark office. Denise is a trusted litigator and a counselor who proactively partners with healthcare employers to address their workplace challenges. Nice to see you, Denise. Thank you for joining us today.
Tim, thank you. It's a pleasure to be here.
And also joining our discussion is Bob O'Hara. Bob is a member of our firm in our New York office. And recently, Bob has focused on helping employers understanding and complying with the OSHA regulations that have become an ever-evolving target during the pandemic. Bob, thanks for joining us today.
Thanks very much for having me, Tim.
I want to start off by, again, thanking both of you for joining today. And you may notice that this is a little bit of a crossover episode. We're not just going to be talking about healthcare providers in the traditional sense. We're going to be talking about their workforce management. And because of that, we're dealing with a different agency than we sometimes talk about here on the podcast. Oftentimes we'll be talking about CMS or the FDA, but today we're talking about the Department of Labor and OSHA and the standards that they've developed for protecting employees of healthcare employers. And it's a little bit different process than the standard CMS rule or an FDA rule. And I was hoping, Denise, that you might be able to give us a little bit of a background on how we got here today.
Sure. On June 21st of 2021, OSHA issued an emergency temporary standard to protect workers in healthcare settings from occupational exposure to COVID-19. The emergency temporary standard, ETS for short, it took effect immediately, and it served as a proposed permanent standard. Under the OSHA Act, the ETS would stay in place until it was superseded by a permanent rule. But that permanent rule was to be in place within 6 months of the ETS. OSHA was unable to meet its deadline. And as a result, in December, OSHA withdrew most of the ETS with exception of the record keeping and the reporting obligations. But when it withdrew it, it cautioned healthcare employers that they would need to continue to comply with the ETS to satisfy their obligations under OSHA's general duty clause, as well as its other standards related to respiratory protection and PPE. And then in March of this year, the agency reopened the rulemaking record in part to allow for some new data, including data related to Delta and Omicron variants, which was not available when it initially implemented the ETS. And it also sought data related to vaccination. It also opened the record to obtain some additional comments on specific provisions that were in the ETS. And it added new topics, and we're going to discuss some of those topics today. So after reopening the record, it also asked for written comments on the topics it identified, and those comments were submitted by the deadline of April 22nd. And then it held a virtual public hearing in late April, early May about the new topics and the additional data as it relates to vaccination, Delta and Omicron. And at the conclusion of those public hearings, OSHA reopened the docket to allow for submission of post-hearing briefs and comments. And it also allowed any stakeholder, meaning anyone who had any interest, even if you hadn't previously submitted comments, to submit additional information and data relevant to the proceedings, as well as final written briefs and those are due May 23rd. After OSHA receives all of that information, it will review the entire record and will issue a final rule based on the record.
How common is it for OSHA to have sort of this disjointed process where they were issued temporary standards and had a deadline that they failed to meet and then reopened it?
I don't think it's very common for them to issue an ETS. There has to be a grave danger at issue that they're going to take immediate action.
Yeah, to Denise's point, this is not a very common occurrence. The ETS mechanism, they have it because it has to be something very significant. They use grave danger as the standard, which is a very high standard. And they've only done it a handful of times in the history of OSHA. And their track record for this is pretty poor, frankly, to actually get these things to work properly. So in this case, they ran into all kinds of court cases and a lot of people were pushing back, a lot of organizations were pushing back, and they really didn't quite get it to the finish line. As Denise said, they didn't get to the 6-month window. They have a 6-month jurisdictional window to actually move from ETS to permanent standard, and they didn't get there. They claim they're continuing to do it just like they thought they did, but it's obvious that they didn't make the right deadline. But it's an unusual sort of occurrence. And I have to say that everything that OSHA has done during the COVID experience has been somewhat unusual, just based on the nature of the issue.
So not entirely surprising given how unusual COVID has been in general for everyone to deal with. I know you've spent some time, Bob, assisting clients with complying with the temporary standards and responding to OSHA audits under those standards. So what has that been like?
Well, it's been very interesting. I will say it that way. The standard approach that OSHA takes in any kind of an investigation, they do certain things in a particular way. So, for example, if there's a complaint raised or there's an issue that's brought to their attention and they want to investigate, they'll give notice to the organization, and then they'll typically show up. They'll come to the location, they'll come to the facility. If it's a death case or a serious injury case or whatever, they're there very quickly after they get notice of that. And the whole purpose behind that is, from a safety perspective, to eliminate any repeats of whatever the issue happened to be: fall, safety, needle sticks, whatever it happens to be. During COVID, however, because of the nature of the pandemic, OSHA, they would not allow their investigators anywhere around the country to go on site to conduct an investigation. And that made a very interesting, problematic, I think, way of going about conducting an investigation, because it was all via email or phone call or paper transferring back and forth, highly inefficient. OSHA recognized that it was inefficient, but they were protecting their own people, which made sense. They didn't want their people going into an organization that actually had serious COVID exposure issues. So that's what they did. And so that was the first impediment to getting things done. And recognize the 6-month window, when you launch an investigation, and when OSHA launches an investigation, they have 6 months to conclude the investigation. Otherwise, their jurisdiction runs out under the statute. So they were very conscientious about that. But oftentimes we were seeing investigations like right up to the very last minute, notices of violation being issued like the day of or the day prior to the end of the 6-month period. So people were starting to track that because they were so overwhelmed with COVID cases in the US that it was really hard for them to get through their work docket for the most part.
So if I'm tracking that correctly, they have 6 months from notice to conduct an investigation, but they also had 6 months from the publication of the temporary standards.
Right. It's a different standard, but it's the 6-month jurisdictional framing is what OSHA has under the statute. And the purpose of that is, we're talking about safety. We're not talking about public policy way into the future kinds of issues. It's really in the moment, trying to figure out what the issue is and getting it redressed. So if there's a safety issue, a threat to, harm in the workplace, they want to fix it right away. They want the employer to fix it right away and not have to wait for 2 years for it to, to go through litigation or anything like that. Similarly, with the regulatory regimen that they have, with this type of thing, it's very specific because it's so unique. If it's so grave that they have to have a standard for this established, they need to do it very quickly. And so the 6-month period was put into the statute specifically to force their hand to get it done. And that's what the 6-month comes from.
But driving to that, we had 6 months of the emergency temporary standards, and the investigations for clients that you've been working with also have gone for 6 months. So do you have investigations, or have you had investigations that were ongoing after the close of the temporary standards?
There were a number of things that OSHA was doing. There's the ETS for healthcare, and they were doing other things more broadly. There were lots and lots of investigations that were launched, hundreds of investigations launched, lots of different thousands of complaints made on a variety of forms, but they didn't pick all of them up. But they did pick up hundreds of investigations, and their people were strapped. So, for example, I managed a few dozen death cases for our clients, various clients, some in healthcare, some not in healthcare. And some of these locations were being managed by OSHA officers, investigators, not anywhere near the location of the facilities, because again, they weren't going on site. So we had some facilities in one part of New York that were being managed out of a completely different part of New York, not anywhere, like 5 or 6 hours away, which would never, ever happen in the pre-pandemic OSHA world. It was all, virtual and, like I said, emails, phone calls, things of that nature, highly, highly inefficient.
Turning back to the permanent standards that we're discussing today and that OSHA is working on bringing towards issuance, Denise, do you expect those standards to be different from the temporary standards?
So based on the topics that OSHA identified that it wanted additional comment on when it reopened the rulemaking record, I do think we're going to see a more flexible standard. In particular, OSHA is considering restating various ETS provisions as broader requirements. The ETS was very specific as to how employers were required to implement policies and procedures in the ETS. For example, criteria for medical removal, return to work, and cleaning. And OSHA has signaled it's considered restating those various provisions as broad requirements without the same level of detail. So giving employers more flexibility in terms of how they're going to accomplish those broader requirements. OSHA has also identified as one of the topics it wants comment on is a safe harbor enforcement policy for employers who are in compliance with the CDC guidance applicable to the issues. Some of the other topics that OSHA has asked for comment on that signal that there could be some more flexibility is the fact that it wants comments about tying the infection control measures to the level of the community transmission of COVID-19. And we've seen that when we look at some of the guidance the CDC has put out for other employers, looking at the community transmission level. So that would mean that certain controls, such as protective equipment, including face masks, would be required only when a community is in a high or a substantial transmission level, rather than at all times during a pandemic. OSHA is also assessing whether there's a need for infection control measures in areas where healthcare employees are not reasonably expected to encounter people with suspected or confirmed COVID-19. So that would mean possibly limiting cleaning requirements and medical removal only where staff are exposed or expected to be exposed to COVID-19. Based on those topics, we do expect to see a little more flexibility. In terms of other changes, there is a chance that OSHA will expand the standards coverage by removing the scope exemptions that were in the ETS. So the ETS exempted certain healthcare workplaces from the standard, including non-hospital ambulatory care settings, provided all non-employees were screened for COVID-19 symptoms prior to entering the facility, and then they were precluded from entering if they had those symptoms. Another exemption was for hospital ambulatory care settings as well as home health care settings, provided all employees were fully vaccinated and all non-employees were screened prior to entering. So if these exemptions are removed, it's going to result in a standard covering many more healthcare providers and facilities, including where services are provided at non-hospital facilities, which certainly is going to extend the scope of the permanent standard. And then some other potential changes that the standard may include is redefining fully vaccinated. That definition did not include a booster in the ETS, looking at employer support for vaccination, including time off, and then finally looking to see whether the standard should align in some ways with the current CDC recommendations.
So hearing all of that, and that's a lot to digest for providers, a couple of highlights I wanted to follow up with you on. First is, are you talking to clients, and are clients excited is not quite the right word, but are they looking forward to that flexibility? Or is it going to be a greater burden on them to now have to try to read between which line they're supposed to be on?
I think it can cut both ways, but I do think it will be a challenge for employers if the standard says you need to look at the community transmission, right? And that the controls that need to be in place will vary depending on that transmission. And I say that's going to be a challenge because if we continue to experience the boomerang of infection rates where they're up and they're down and they're up and they're down, then there's a constant change in what those control measures are. So that's changing your protocols, communicating those protocols to your employees, making sure they understand the change. And then when you have those constant changes, it's hard to remain compliant because you're in flux at all times. I mean, we saw that with the CDC changes with non-healthcare employers, where the standards were constantly changing as to when to quarantine and isolate, depending on vaccination status and date. So when we see those changes, compliance is certainly difficult for employers. Likewise, if the standard does provide that the control measures are limited to only those areas within the facility where there's an expectation that you're going to encounter someone with COVID-19, that could result in bifurcated control measures, meaning a portion of your workforce is going to have to wear a mask every day and do the employee healthcare screenings, and another portion of your workforce is not. And again, that also creates challenges from a compliance perspective. And I think it also creates challenges from an employee morale perspective when you have those bifurcated standards.
Certainly. And one other highlight from your comments I wanted to point out is we're going to have providers who are employers that did not have to comply with the previous standards, if our crystal ball is correct, that will have to comply with the permanent standards. And some of those providers, if I heard you correctly, might include home health providers where care is being given. And that seems to me that would be in particular a sort of a nightmare to comply with, given the various settings that those types of providers are providing care in.
Yes, well, there's certainly going to be some, if as OSHA signaled, they may remove the exemptions, it is going to be a broader scope extending to additional employers. And I do agree it will be a challenge for some of those, especially in the home health setting, to comply.
Bob, as Denise just pointed out, we're expecting these changes when the permanent standards are eventually issued. Do you expect these changes to make significant differences in the way, or have a significant impact on the way OSHA is enforcing the standards?
No, I don't think so. I think if you look at the history of the enforcement mechanisms that they employed during the COVID period for the last 2 plus years, OSHA is very specific in what they go for. They go after, and particularly in the healthcare space, the vast majority of violations, even as recently as this month, have been related to the respiratory protection programs that are required by healthcare facilities. So fit testing and the record keeping aspect of the programs that they have, that's where most of these violations are stemming from. We talked very briefly about the general duty clause. That's a very amorphous, high-level 1.5 sentences of statute that says you as an employer have a duty to provide a safe workplace. Okay, thank you very much. What does that mean? How does that operate? And OSHA was really hard-pressed to bring claims against employers under the general duty clause because of the generic nature of what the statute said, the statutory language. So they would go and follow record-keeping issues. They would go back to training issues, things that you should be doing as a healthcare provider, and perhaps we're not up to date on those. Lots and lots of allegations and lots of violations as a consequence of that. So they go back to the place where they know best, which is the record-keeping component of that, because the regulations are voluminous. And it's not easy to get them right, particularly in a situation where you have shifting fact patterns, CDC guidance, who's on first, community standards. All of those variables make it increasingly difficult to comply 100% of the time. OSHA gets that, they know that, but what they're trying to do is build the proper framework. Whether they get there or not, with a final standard remains to be seen. I can tell you it will be challenged regardless based on the jurisdictional extension that they went beyond. It'll be challenged immediately. And I think that employers are looking for clarity. We talk about flexibility. Flexibility is one way of putting it. However, clarity around what we have to do is essential. All of our healthcare, companies and clients want to protect their people. There's no question. The manner in which they're being, either forced to do it or, go beyond the standard is really the challenge that they have. Let alone the things that Denise talked about, which are, pushback issues from employees and different types of organizations inside of an employer. Those kinds of things are going to be tested all along the way on those types of things. And I think OSHA recognizes it, and they're trying to thread the needle. Whether they do it well or not, I'm skeptical, but we'll see.
Just following up on the potential judicial challenge, is the expectation that will occur almost simultaneously to the permanent standards being published?
Well, I think it would be fairly close on to whenever they've put some standard out there. They would have to wait to see if they put it out and say it'll be effective on such and such a date. The challenge might have to wait until the effective date, but maybe not, particularly because it's a jurisdictional issue and that they're putting something out there. I think it'll be very, very closely aligned. There are plenty of organizations out there that have already telegraphed that they would challenge it.
And so we'll have a judicial challenge most likely, and that will have another timeline associated with it. So we'll have had temporary standards, permanent standards, potentially a challenge to those permanent standards, which may or may not involve some sort of judicial pause on their implementation. Just thinking of the headaches that employers are going to have dealing with this.
Indeed. And that's the challenge that they've had all along. When OSHA would put something forward and then they would be challenged and, all right, who's on first? Do we or don't we have to follow this? What is it that you want? Tell us what it is that we have to do and we'll do it. We'll go and do it. But you got to tell us what it is. And frankly, OSHA was always struggling with how to help people do this. I was on the phone with OSHA several times a week for 2 years, and they were as challenged by it as anybody else. They recognized the difficulty. It wasn't like they said, oh, everybody knows what to do. They knew that was not the case, and that they were trying to make it clear, and they were getting a lot of feedback from a lot of different quarters to try to make it different. This is why, having an airborne pathogen standard, which is what we're talking about here, has never been done, because it's very difficult to frame it properly. Now, this is being framed specifically with COVID in mind. So it's even more specific and particular. But as we all know, and I've lived through for 2.5 years, there's nothing, nothing routine about the COVID experience that you can say that, okay, we're going to put this in a paradigm and we're going to make this work. It's very fluid.
You said something there that I'm going to ask you an unfair question about. Do you see this going towards other respiratory standards that are transmissible after COVID? Are we going to get flu standards for providers at some point from OSHA or other communicable diseases?
That's the thing, the airborne pathogen standard. I mean, they have a bloodborne pathogen standard that the healthcare facilities all know about how that works. But airborne pathogen can be a variety of things. It's tuberculosis, it's flu, it's all manner of things. And the nature of airborne pathogen is such that they have tried in the past to get this started. I think last time was maybe 15 years ago. They tried earnestly to try to create something, but it never came to fruition because of the complexity of the issue. If there was a single issue that they were going for, say flu, even there you have a wide variety of flu responses on an annual basis. There is no one type of flu. So that's the challenge for an airborne pathogen standard. So if they want to do something that's more generic, then they would have to come up echelon in the strategy of how they want to enforce this so that other things that fall underneath it, COVID, flu, TB, or whatever, would sort of flow underneath it. But you lose particularity then when you do something like that. I'm not sure you're in any better place, and perhaps that's the reason why they've never really been able to get it done. People have been clamoring for it for decades, but they've never gotten it there, but not for lack of trying.
Thank you. We're starting to close in on our allotted time for our recording today. So I wanted to take a moment and ask both of you what you think the most important takeaways are from the new standards for healthcare employers.
I think that they're not going to be simple, even with the flexibility built in. You're going to have to research them. You're going to have to look at them. You're going to have to rely on advisors to sort of help you wade through it, because every organization is unique. There are some similarities, obviously, in the healthcare space, but each of these organizations are unique in how they apply their people, where they put their people. And OSHA is trying to figure that out by putting a standard out there. So you're really going to have to be, for lack of a better phrase, the devil is in the details when it comes to this type of a thing. And so once these things get launched, assume that they're not challenged, but try to figure out how to make them work for your organization, and then put them into place. I mean, those are the kinds of things that I think that people should be thinking about, and I'm sure they are. I mean, you've lived through the COVID period for the last 2 years, so much of what we're talking about is not going to be new. The manner in which you do it and the record keeping which you do might change, and the frequency of how you employ it might change. I don't think they're coming out with anything novel in the way, like a new tactic to use to combat COVID. I think we've been down that path many times. It's just a question of now putting it on paper.
Yeah, I agree. I think employers are going to be facing some challenges in terms of deciding how to go forward with some of the measures if there is some of the increased flexibility that we expect. It does give them an opportunity to look back to see what worked and what didn't work when they had the ETS. And even though the ETS was withdrawn, many are still operating as if the ETS is in effect. So I think they can use that to say, hey, what worked, what didn't? And are we allowed to make any changes based on what we expect to be a more flexible standard going forward? But that's not easy, because you also are always confronting whether it's unions or your unrepresented workforce in terms of what they want and what they expect. And that's never the same. So you have some people who want very conservative standards and some people who want a lot of laxity. So making sure that they're complying with the standard and then also doing it in the safest manner as possible to make sure their workforce is safe, while also managing that employee morale perspective. And I think another thing employers should keep in mind is that we're going to continue to see an emphasis by OSHA as it relates to enforcement of this new standard, the general duties clause in general. So I think they should expect that whatever decisions they make, they have to make sure they are in line with the new standard and make sure they're following them.
Denise and Bob, thank you very much for joining us today. It was a pleasure having you both on.
Thanks, Tim.
Thank you very much, Tim. Appreciate it.
And I want to thank all of our listeners. I'm your host, Tim Murphy. If you like what you heard today, don't forget to subscribe. Diagnosing Health Care is available wherever you get your podcasts.
Thank you for listening to Diagnosing Health Care. For show notes on today's episode, additional episodes, and more insights on trending issues in healthcare, please visit diagnosinghealthcare.com and be sure to subscribe on your preferred platform. The Employment Law This Week and Diagnosing Healthcare podcasts are presented by Epstein Becker Green, PC. All rights are reserved. This audio recording includes information about legal issues and legal developments. Such materials are for informational purposes only and may not reflect the most current legal developments. These informational materials are not intended and should not be taken as legal advice on any particular set of facts or circumstances, and these materials are not a substitute for the advice of competent counsel. The content reflects the personal views and opinions of the participants. No attorney-client relationship has been created by this audio recording. This audio recording may be considered attorney advertising in some jurisdictions under the applicable law and ethical rules. The determination of the need for legal services and the choice of a lawyer are extremely important decisions and should not be based solely upon advertisements or self-proclaimed expertise. No representation is made that the quality of the legal services to be performed is greater than the quality of legal services performed by other lawyers.